The roots of modern epidemiology. Now, this is very important. Epidemiology emerged out of the infectious disease specialty, and when we look at the history, you can see the significance of all of the infectious diseases and the profound effect they had on death. And so if somebody wants to know from you, where did epidemiology come from, it's infectious disease. And we still have infectious diseases, and we have different variants of the flu, and they have the potential to have a great effect on longevity and on death. Now, I'd like to talk to you about what is the purpose of clinical practice versus what the purpose is of epidemiology. When we're talking about clinical practice, and please, I'm not casting dispersions on clinical practice. All I'm doing is making a contrast here. When we talk about that, we're talking about really treating people one at a time who have a disease. And one of the things that you're going to hear me talk about over and over and over again, and I want to share this with you, is that one of the elements that should come from a physician visit, or a visit with a nurse practitioner, or a visit with any practitioner in the medical profession, is a diagnosis. I know when I was a student at Stanford, they would prescribe no medication until they took a blood test. They wanted to make absolutely certain that what you had, they could treat effectively with the proper medication. And we've had all kinds of problems with antibiotics. There's an emphasis now on developing new antibiotics. The public has an expectation when they go in to see a practitioner that they receive something, and they're impatient and they want it now. But the idea behind medicine long ago that diagnosis informed treatment, and somehow that seemingly has slipped away. Now, what is the purpose of epidemiology? We want to prevent, protect, and control diseases in human populations. So let me say it a little differently. It's a population-based approach for the intervention among large groups of people, and whereby you use inexpensive interventions that follow the principle of Occam's razor or parsimony. So they're not designed to be expensive, but to be effective. And if you can design an intervention that impacts 1% of the total population of the 300 and some odd people in America, that would have a profound effect in numbers in terms of helping that population with a cure or some type of prevention of a disease. Okay. Epidemiologists versus clinicians, and you can see this very clearly for yourself, and I'm not going to read it to you or go over it, but I want you to notice the difference, because I hear people say, well, I'm a public health X, and if you're a public health X, you're going to fall into the epidemiology area, and you're not going to be seeing one person at a time. Your focus is on how to treat a population, and your primary factors are prevention, protection, and control versus examination and diagnosis, and you're going to be patient-based, and you're looking at a treatment and a cure. Okay? Why do we need epidemiology? Now I'm talking about, this is descriptive epidemiology, and this is what you want to be good at. It's not simple. Higher order reasoning is definitely involved, but epidemiology fills the gap between clinical practice and laboratory studies. Okay, alone, neither specialty represents the true picture of what causes or cures most diseases. So we want a marriage. We want a marriage to confirm what it is that we're dealing with. Oftentimes we're getting reports so we can look at trends that come out in the MMWR, and this comes from clinical practice, and there's a reporting procedures. Let me just take sexual diseases. They're reported, the practitioner reports those by name to the local health department, and then that goes on to the state health department with the name associated, and then the name is stripped when it goes to the CDC. Now the reason for the name element is so that we can look at others who have had contact with this particular person, so that the problem doesn't become worse. Okay, now descriptive epidemiology relies heavily on, boy, I've really hit this hard, haven't I? Clinical observations, descriptions, trends and patterns, and I told you where we're getting that data, and oftentimes it's from clinical practice and laboratory studies with a diagnosis. Has to have a diagnosis, otherwise we don't know what we have. Next, abnormalities or anomalies, things that are out of the ordinary we're looking for. And we want to do descriptive statistics, and this is where we are using epidemiologic statistics, not social science statistics, as I mentioned before. The next area that sort of grew out of in the order of history was behavioral epidemiology, and we had a real problem in our country in the 80s. It was called AIDS, and we didn't have a treatment for it. And we found out that all diseases are not due to genetics alone. There are often social, behavioral, and environmental factors. And we had diseases that were related to gratifying the flesh, if you will, and that were very much resistant to change. And there are many barriers in behavioral theories designed to help with behavior modification under these circumstances, and we had no treatment that was available for AIDS at that time. And also what usually goes on is a number of hypotheses when we have a disease that we can't treat is inversely related to the amount of available scientific information available or knowledge available. So we have multiple hypotheses when we don't know the determinant or the cause of something. So social science came on the scenes at that time, and to focus on AIDS and prevention and control through behavior modification. That was the way that we had to move, and we needed to move quickly to teach people that probably the best and most effective method of dealing with the public health problem was through bleaching needles, wearing condoms, and abstaining from sex. So if we could get the public to do this, we thought at least we could reduce the incidence of AIDS and or morbidity and mortality. The next area I'd like to talk about is behavioral epidemiology. We talked about epidemiology up until this point, and behavioral epidemiology became a new field in the 1980s. There was a lot of hysteria, and the reason it became a new field is because there was a lot of hysteria in the U.S. about AIDS. And of course, AIDS coming from Africa, and it was spread from animal to man, where a monkey bit a man that had AIDS, and so it was a new disease, but we had no cure, and so people didn't know what to do about this. They were at a loss, and of course, again, I want to say to you, the number of hypotheses is inversely related to the amount of scientific knowledge or information. So we had a plethora of reasons why this was happening, but no good scientific evidence. So we know that that genetics is not the total reason why people get sick, and so we begin to look at the social and behavioral environmental factors around AIDS and what we could do and what clinics could recommend and suggest. And so this started the field of behavioral epidemiology, and you can see toward the bottom of this particular slide that with AIDS, we could prevent it and control it through behavior modification. Also, around this time, 1978, was the outgrowth of behavioral medicine, treating medical problems with behavioral techniques, and that society is still in existence today. It was one started by my boss at Stanford. But as you notice here, you'll see that the modifications have to do with the recommendations were the bleaching of needles, wearing of condoms, and abstaining from sex. Had nothing to do with medication or medicine, but it had to do with people taking responsibility for their behavior, and these are the ways that they could avoid getting AIDS at that time, for which there was no cure. So that's behavioral epidemiology. I'm going to go on and talk about it more. And I want to give you the definition of it. It's not very much different than the prior one that we started with in terms of epidemiology, except based on the focus of unhealthy behaviors. So if you look here in the definition, we're talking about human populations related to engaging in unhealthy behaviors and making behavioral choices deleterious to one's health. So the focus is on behavior. And let me just talk about that for a bit. Most of you have heard about Albert Bandura and observational learning, and it seems to be that what we see is what we do. And for example, we think that there's a relationship between television and depression because we don't meet all the expectations that are portrayed on television, such as being beautiful, wealthy, and popular. And many strive for these ideals that they can achieve, and being as slender as a model as we see on TV, or having the same muscle bulk or looks as the male stars that are heralded as the ideal. So there's a lot of other factors, and I'll cover those in a minute, that have to do with ideals that we don't seem to live up to, that have a deleterious effect on health. Now, when you look at poor health habits, and these are all behaviors again, and ways in which we could improve improve our health. We make choices, and they say you eat about 100,000 meals in a lifetime, so you make a choice routinely about what you're consuming. And one of the things that we consume are cigarettes, and we know that cigarette smoking is deleterious to our health, and eating sodium-rich foods and high-fatty foods, and not engaging in exercise, and exposure to UV light, stress, alcohol abuse or misuse, and illicit drugs not forbidden by law, and illicit drug use. So, of course, these are all things that are not good for us. And these are all behaviors that can be modified and changed. And I don't know that previously I was alluding to body weight. And the two problems in body weight is a low BMI and a BMI above 30. These are the ones that seem to cause health problems, and especially as you become morbidly obese. But I don't want you to forget the underweight category. That's just as serious as the overweight category. So we have a great influence on our longevity in terms of our own human actions, those behaviors that we engage in on a routine basis, as I'm talking about here. Now, I wanted to sort of lay this out for you, since it's a relatively new field, and etc. Now, of course, we know that cigarettes are designed for addiction, and mentholated or menthol cigarettes are more addictive than any other type of cigarette. And so if we look at the determinant, we're looking at the type of cigarette, because we're looking at the addictive properties, and we want to know how many cigarettes people smoke, and then what does that behavior lead to in the way of disease. Well, in this case, oftentimes people think it's cancer, but really the leading cause of death related to cigarette smoke is heart disease, and you know that has to do with the constriction of the arteries, and not getting proper oxygen, and the heart having to work too hard. Stress, and you've got plenty of that in your life, and it's interesting that we don't teach anything about stress on campus, especially to our undergraduate students, and how to manage it. But the behavior is poor maladaptive responses to a workload, and you can see the disease. Now, I'm not going to go through every one of these, but I want you to notice the relationship between determinants, behavior, and the disease. This gives us an opportunity to intervene by focusing on the behavior. Examples of the risk factors. Well, when we look at behaviors, again, cigarette smoking, physical inactivity, not wearing a helmet when riding a motorcycle or a bicycle, we have found is a significant problem in terms of brain injury. And when we think about other characteristics, environmental exposures, what are the things that we can do in terms of not are protecting ourselves in terms of air pollution and loud music. And then there are human characteristics that we look at, and we know these to be risk factors. That age you can't do very much about, gender you can't do very much about, race you can't do very much about, but the point is is these determinants are indicators of who is more likely to have a disease or die from the disease, and therefore these groups ought to be more careful than others that aren't as susceptible. Okay, and what do epidemiologists do? Well, they identify health risk factors. We talked about some of those. They describe the etiology of a disease, its origin. They identify populations at risk, and they prioritize public health threats. Now, this last one, is in the Surgeon General's Healthy People document. Now it's 2020, but we prioritize the diseases by age groups that are most deleterious or the most likely to have a fatal consequence. So I think I'll leave it at that, but that gives you an idea about the prioritizing where we go to look for information about the priority of a disease and whether it should be a disease that we should focus on or not, because we want to focus on those diseases that take the greatest number of lives. Okay, this is I thought you'd find very interesting. Talks about the leading causes of death by age group, and most of us think that, well, after we spend all our time, and of course it's the highest number, but we look at heart disease and we say, wow, geez, look at that number. But you can see where people are dying from unintentional injury, or you might say accident, although we don't use that term. We call it unintentional injury. And you can see that's the leading cause of death between people between 1 and 44 years of age. It doesn't have to do with heart disease. Okay? Even though heart disease is a major problem, unintentional injury is influencing the greatest number between these two ages between 1 and 44. Now let me go to number 2, because we forget about this, and we see that between the 15 to 24 group we have homicides and we have suicides. And yes, that the greatest number of people over 65 are dying from cancer. And then when you look at the third cause of disease, look at this. We have homicides occurring between 1 and 4, and suicides occurring between 10 and 14, and 15 to 24, and then we have homicides and then unintentional injuries. And when you just sort of look at the thread of the homicides coming down, it's remarkable that this is the fifth ranked cause of death among age groups, and suicide is a major concern here, and so is homicide, and unintentional injuries begin to increase, and finally they're the fifth leading cause of death among those when we look at the total. So I hope I've made that clear to you that we get hung up on heart disease, but look at all of this. Maybe we ought to be focusing our attention here if we look at SCIT and primary prevention and education programs that we might employ to protect these people from those causes of death and their motor vehicle accidents primarily, but they also have to do, they deal with other causes as well. Now, these deaths that we're looking at I just want to make a quick point. The most deadly war of all time was the Civil War. And if you add all these up, you begin to add these together. The Civil War during when it occurred, 1861 to 1865, we lost 625,000 Americans. And when we look at that number in relationship to this, you can still see that we're losing far more people to diseases than we are to war. Now, that doesn't mean that every life isn't important and valuable, but I'm just trying to put it into perspective that we have a lot of diseases that we sort of accept and we don't clamor about. And let me see if I can say that differently. We lose, I think it's 10,224 people annually in Indiana to smoking related diseases. That's annually. And in 2011 we lost 4,484 soldiers were killed in Iraq, and in Afghanistan there was 1,889, and that included 2012, so the total was 6,373. So yes, people are dying in war. We have a lot of people that have injuries from the war, are paraplegic and quadriplegic and many mental disorders, but you can see that number is greater than any of these. Now, this talks about the leading causes of injury related to violence-related injuries, and you can see where they occur. They're not in the top row, but they occur throughout this chart, indicating a major problem in our society of aggression turned outward and aggression turned inward. So we have a lot of losses when you look at the total number through suicide and homicide as you examine this chart. So we have the table shows ranks for different causes of deaths, and that's what I was trying to point out. And what are the leading causes of deaths, and what are the deaths that occur at certain ages? And those are all important factors, because we probably ought to be looking at some of those too, rather than concentrating on those that are occurring for individuals over 65. First off, you have to make it to 65, so there's a lot of work that we can be doing at younger ages. And I'll explain 65 as it has to do with longevity later on. Okay, so if you're interested in epidemiology, you have a population perspective, and it's good to have a background in basic biology and physical ecology and social ecology, sociology, social psychology, and economics. All of these interact with one another and are important to understand a particular problem and have to do with the different areas that we concentrate on in public health. But if you're going to be an epidemiologist, you have to have a good statistical or quantitative background. So if you're thinking about moving in that direction, and the salaries for epidemiology, especially at the PhD level, are phenomenal. They're in high demand and they pay a lot. So I want to talk about ecology. Um, we used to think about ecology as having to do with sorting and throwing things away. That was what we thought about mostly when we talked about ecology. But you can see, and that example that I just gave underscores the interaction of organisms and their environment. We try to do things to preserve the environment rather than take from the environment. And primarily what we do is we take from it. In public health, we're concerned with the interaction between environments and disease. And the AIDS is a good example of that. We saw that the environment was conducive to a condition or situation that caused it to be more influential, and the disease would occur therefore more often. So environmental factors are important aspects of human behavior and the modification of human behavior. Focus on physical ecology and how it influences the environment are related to disease state. Well, biology, I think, is pretty simple. You know that insects, for example, mosquitoes spread disease, and all kinds of them. And then we have geology, which we're looking at the environment, and asbestosis would be one example. And there are a number of things in our environment that we try to detect and protect people from them. And then meteorology, we know that in hot, humid temperatures, diseases are spread more easily. And for example, you don't have a high incidence rate of influenza in the summertime. You seem to have that during the winter months. So I'm just trying to share with you that I said earlier on that epidemiology is a cornerstone of public health. It pulls together and organizes and utilizes information from a variety of fields, and this gives you some feeling for the various connections that go on that are necessary to make public health a success. So we need contributions from all of these areas. Now I want to talk about social ecology, and this is a relationship between behavior and disease, and I put it under the environmental area, and that's okay, but social aspects, you have to, for AIDS, people had to interact with each other, and you can see the graphic on the right, and you can see the number of people that have built resistance to antibiotics, and as a result of antibiotics being given so freely, we lose the ability to control a disease like MRSA, because nothing seems to work, because we do have resistance to the antibiotic. It also has an influence on the organizational culture of hospitals, and now what are you going to do if you have a patient with AIDS? There's all kinds of restrictions that need to go on, and many of you know this better than I do. Are you going to quarantine them? What are you going to do with visitors? What are you going to do with? Are you going to put two people with AIDS in the same room, etc., etc.? And we want to make certain that we reduce any medical errors that would exacerbate the problem or make it worse. And of course, you all know that medical errors are a major problem in U.S. hospitals. Okay, now, when we talk about social and behavioral epidemiology, when we talk about sociology, we're talking about social systems and their influence on human behavior. When we talk about behavioral epidemiology, it's a study of the relationship between human behavior, here we go again, the influence of human behavior in social systems, and the distribution and determinants of disease and injury frequency in a human population. Now, through our relationships, the main point I'm trying to get across in this slide is that social science informs epidemiology. It gives us strategies that we can use that follow Occam's razor. We know how things are, we get a better idea about how things are related, so we have a better idea about how we can intervene. So I hope that ties that together for you in your thinking. Now, these are questions that come from social and behavioral epidemiology. How does the social environment, for example, result in differences in quit rates between teen and adult smokers? What is the relationship between socioeconomic status and health? Epidemiological investigation, what does it involve? And much of this you already know, but I want to go over it. And there's classes that are spent on the spectrum of disease and the spread of disease because it's so important. So we have the inception of disease, which we call prepathogenesis, and factors that initiate the disease. We have pathogenesis, mechanism by which etiological agents produce a disease, and we have pathological progression. And the clinical response to the disease we classify as mild, moderate, or severe. So when you're thinking about disease inception, you're thinking whether somebody's at the pre-pathogenic stage or the pathogenic stage, or the pathological progression has reached a certain point that it's much more severe, and the outcome may lead to mortality. So when we talk about the sequela of disease, we talk about remission, we talk about reoccurrence, we talk about unremitting progression and death. And not every disease obviously results in death, but some can. So we know that if you think about a disease in remission, you think about cancer. Well, we talk about somebody being in remission. A lot of debate about what remission is. Is it temporary reduction in signs and symptoms, or do signs and symptoms become undetectable for a while, but and it's due to the lack of sensitivity and specificity, and I'll cover those terms of our equipment and detection methods. In some diseases, they reoccur. Cancer's a good one to look at. We have other diseases like influenza that you have it once and then you're well, and then you get it again. And then we have some diseases that just are going to progress to an endpoint that's going to result in death. So I hope this sort of helps you in ways to organize your thinking about disease in a systematic way. Now, all of these don't have to be included, but again, I want to talk to you about something that's so basic in epidemiology that it's often forgotten, and that is to define a case based on criteria. And what makes it difficult, if we don't define a case the same way, we don't progress in science in the treatment of a certain disease. So if we have multiple definitions of what a case is, we're really treating multiple problems and not a singular problem. Or if we don't have a case definition at all, and you'll read articles that don't have them, don't have a definition of a case, you don't know who really is being treated at all. Now here's another way in terms of the spectrum of disease. We talk about exposure. These are the stages you go through. You're exposed, you have a pathological progression, you have signs and symptoms, you may or may not have disease onset, and then you either have progression or reversal, disorder or disease, which the progression would lead to death, or a reversal of the disease where somebody may get better or actually remain the same but not get worse. So it says here, the red text appears repetitive. Don't let that bother you. Also, not everyone with the disease dies from it. So this chart can be somewhat misleading. So, but what I'm wanting you to take away is that you're going to have exposure, you're going to have a pathological progression, you're going to have signs and symptoms, and you may or may not get the disease, or you may or may not display the disease, as Typhoid Mary did not display symptoms of the disease, and yet she had it and was a carrier. Okay, case versus non-case, you can see I'm really harping on this. A case is what you define it to be, but you have specific criteria. And what happened to us in about 1988, we were using criteria for AIDS, and we were classifying people according to meeting specific criteria, and then we changed the criteria. So after 1988, we couldn't use we couldn't use the data prior to 1988, because once you change the case-dom or case definition, you're comparing two groups. Now, in order to have a case, you have to have a diagnosis, and so otherwise you have a very heterogeneous group of people that are sick. So it implies a dichotomous or a binary distinction, either yes, you are diseased, or no, you are not. And as a non-case, is someone who doesn't meet the case criteria. They don't fall into this particular disease category and wouldn't be people that we study. Now, I'm presenting this as a simple issue, but it's been debated often in the course of medicine and epidemiology as to what is a case. And that's what we were trying to decide with AIDS. And obviously we thought we had a definition, when in effect that definition changed and made data prior to 1988 useless. Okay, now I wanted to switch here because this is a behavioral example. This is a psychological example, rather than always focusing on physical health. So we're looking at somebody that might be maritally happy versus relatively happy versus distressed. And here's the criteria. And this is the marital adjustment scale. I have used it myself. There are 15 questions, and they categorize people pretty neatly into these one of these three categories. So you can decide whether or not people should receive help or not, or the couple can. And what's interesting about this too is oftentimes those who are maritally happy want to do things to increase their happiness, so it doesn't have to be for pathological reasons that we apply techniques. So we could look at this as primary, secondary, and tertiary prevention. So that's another way to examine these three categories. I keep trying to bring the vocabulary that we've covered back in so that you can utilize it as I am as we go along, so that you learn it and know it well, because that's application. Okay? Now, I've already mentioned this. This is problems with case definitions, but it's been written down, and I won't go over it because you can read this slide just as well as I can. And you know that case definitions do change, and that's a serious thing, and we just lose vital data because we haven't made a good definition from the outset. Now, steps of an epidemiological investigation. We always want to begin with determining the magnitude of the disease. How big is it? Now, you know right there that brings into all your that brings together your vocabulary. When we're talking about magnitude, we're talking about distribution, determinants, and frequency. We're talking about a diagnosis. We're talking about incidence and prevalence, and I would add the word rates there for you. And then, so we want to know, what is the trend? Is it different from the endemic state or the baseline state? And we would want to know, is it an outbreak? Is it an epidemic? Is it a pandemic? So we're looking at person, place, and time variables again. Number two, we want to look at the etiology of the disease. We want to make certain how this disease seems to be spread. We know that greater than 75% of the diseases, are you ready for this, are spread from animals to humans. So, or is it being spread by insects, or how are people contracting this particular disease? Number three, we want to know about the natural history of the disease. And really what this is talking about is the endemic state. Has it always been at a low level? Is it a holioendemic disease? Is it a hyperendemic disease like AIDS and other diseases that stay at a high level all the time, like heart disease? So what is the trend of this disease? Is it low, high? Does it affect kids more than adults? So all of those distribution factors are very important here as well. Now, we're going to develop a prevention program, and you remember that prevention is treatment. So whether you're talking about primary, secondary, or tertiary prevention, you're talking about some type of treatment. Well, in public health, what we're hoping for is a population-based approach. So we want to do something that's inexpensive, that has great influence across the population. And sometimes we can do something that's very minimal and only influence 5% of the population, but when you translate that into actual numbers of people that are influenced, it's a horrendous number. So I want you to keep that idea in mind as well, that a minimal effort can have great impact on huge numbers of people. We call that a minimal intervention, or again, following Occam's razor, as parsimonious. Okay, we want to be able to evaluate new preventive measures, and what happens? Does a preventive measure work? Does it not work? How can it be improved? What are we going to add to it? How can we still keep it simple if we're going to add something to it? All the time we're thinking about money and the economics of it, because we can't use expensive methods for everyone. We've been trying to do that, and of course it's been breaking the bank. We need to look at things that we can do for the population that will prevent them from needing hospitalization or needing extensive medical treatment and care, and we can look to behavioral, sociological, and other ecological approaches that might provide information about how to address this problem. So we have to, we need an implementation system, and sometimes what we're doing is we're looking at policies or laws, and policies and laws are different. Laws are set by Congress. Policies are usually set by companies, and sometimes policies and laws overlap. But we might have a policy in our own town where we would purify the drinking water. We know that the drinking water in West Lafayette is potable, but oftentimes it is filled with a lot of metals and rust. So, and as Snow did, he had a policy: water collection restricted to one well not contaminated. He shut off the contaminated well and water supply. So